Thank you all so much for being here today, for joining me. My name is Andrea Johnson. I'm the ECMO program coordinator from University of Missouri. Thank you all for joining us today. I'll be presenting on electrical impedance tomography, assisted ventilation and oxygenation management of adult ECMO patients. So disclosures, this is a sponsored talk by Temple Medical. I just want to thank them for their support and all the help that they've given with this presentation and the use of EIT at our facility. About me, I am a registered respiratory therapist for over 16 years. I've worked with all age groups. Now, currently, I just work with adults, and our facility only does adult ECMO at this time. I graduated with a Bachelor of Health Sciences from the University of Missouri. I obtained my Certified ECMO Specialist adult credential from the International Board of Blood Management, and I am currently the ECMO program coordinator for University of Missouri Healthcare. By the way, if any of you ever have, one of my favorite things to do as a coordinator is, as ECMO programs grow, there's so much help in the field from other centers that I've gained. So if any of you after this talk want to reach out to me about your ECMO program and growth or anything, I love talking ECMO to anybody. And I also love admitting that I get a lot of tips from other people. So would love to get people's contacts to help share knowledge. So in terms of our content today, we're going to go over some recent EIT that's been shared in the Respiratory Care Journal, the specific aims of the project that I'll be presenting to you all, background and significance, how EIT is set up. I know that EIT may not be a familiar technology for a lot of you, so I'm not going to necessarily go step by step, screen by screen as to how EIT is used, but as a respiratory therapist, as someone that is at the bedside, when somebody's talking about doing something new, bringing something new into the room, I want to know, what's that going to look like in my patient's room? So we're going to kind of go over that in the upcoming slides. So preliminary data, I'm going to present to you a couple of our patients that we were able to use EIT and ECMO together. Our first patient, patient A, had influenza, MSSA pneumonia, aspergillosis that resulted in ARDS. Patient B had influenza that resulted in ARDS and acute renal failure. We'll go over our results in graphs. And then I'm going to kind of share with you what our institution's research plan is moving forward. So this slide features a graphic that some of you, if you are part of the AARC and get the Respiratory Care Journal, may have gotten. I was very excited to see this in my inbox, I think last week or it might have been the week before, where the Respiratory Care Journal was highlighting some journal articles and abstracts that they had accepted for publication about EIT. So you can see here that they're talking about how, compared to CT, EIT was found to be accurate and consistent in measuring regional dynamic ventilation. EIT was utilized to identify phenotypes of ventilation patterns associated with increased post-op pulmonary complications, and even looking at how EIT looks compared with using APRV and low tidal volume ventilation to see how that can better gas exchange and compliance. You can see on the right side of that slide, it's actually been used. I haven't read this study yet myself. It's just a manuscript that I know that has been submitted that's about decreased time on ECMO that was guided by EIT with neonates with ARDS. So really exciting stuff coming up in the world of respiratory care being affected by EIT. So really the take-home message from this is that while it's not considered a diagnostic tool, EIT provides an alternative to CT to evaluate distribution of ventilation at the bedside, and that it can be used with adults and children, which, what a great thing to have this technology available across all age groups. So this presentation that I'm going to be sharing with you all today is actually an expansion of the abstract that I presented at this past year at the 35th annual ELSO conference. ELSO, if you're not familiar with ELSO, is the Extracorporeal Life Support Organization. So they are an organization that since the late 1980s has been around collecting data from different centers to help us create our guidelines, to create our protocols, to help expand our knowledge about how we manage the ECMO patient. And so I got to present my abstract at this conference. And so I'm going to be kind of sharing this with you all today, but also expanding upon the work and findings for you all. So looking at the aim of our project helped to address what I know are some barriers at the bedside as an RT. So what should we set our PEEP at? What does it change? Does that change with positioning? And when we do bronchoscopies, does that help? Should we repeat it? When should we be repeating it? So the aims of our project, we're utilizing EIT to manage ventilation oxygenation of ECMO by optimizing PEEP, and then utilizing EIT to both monitor ventilation distribution pre and post bronchoscopy and document those changes and or improvements. And then furthermore, look at ventilation distribution to determine the necessity of recurrent bronchoscopies or other procedures and interventions. So again, looking at these constant questions, I think as respiratory therapists we have of what should my PEEP be for this patient when we're going through positioning changes, and did that bronchoscopy in fact help our patient, and where are we seeing those increases in ventilation? So a little bit of background into EIT, if you're not familiar with it. Electrical Impedance Tomography, or EIT, is a bedside, non-invasive, radiation-free technology that can help determine optimal PEEP through real-time dynamic lung mechanics analyses to improve oxygenation and ventilation while reducing hyperdistension and collapse. So that whole statement is to say, when we're using our optimal PEEP maneuver with EIT, we don't want hyperdistension, we don't want collapse, but we want our best compliance. We know that as RTs, and so how do we get there by using this tool and by setting our PEEP? This technology can be useful in the management of patients with acute respiratory distress syndrome who are difficult to ventilate and oxygenate. And if you look at those images on the upper right side of your screen, you can kind of see here just a preliminary EIT image where at a PEEP of 5, less of your ventilation is getting to the posterior segments. With that increase of PEEP, you might have more going to those posterior segments. And we're going to get more in depth into our optimal PEEP tools and how that demonstrates with our patients. And I do have a picture here that also comes from Temple's website of just what it can example look like for having that Temple console next to your bedside with a patient hooked up to it. So in terms of background and significance, veno-venous extracorporeal membrane oxygenation, or VV-ECMO, can be used to limit ventilator-associated lung injury in patients with reversible refractory hypoxemia to conventional treatments. So VV-ECMO limits our ventilator-associated lung injury by allowing for us to change those tidal volumes with decreased peak airway pressures, driving pressures, while hopefully maintaining oxygenation and ventilation. So we know that the great thing about ECMO is that when you have a patient that you've placed on ECMO, by definition, usually when you place a patient on ECMO, you have a patient that has failed conventional methods of vent management. You've tried different things on the ventilator, you've tried proning, you've tried inhaled nitric oxide, you've tried medical paralytic, but they failed to maintain appropriate ventilation and oxygenation. So by placing them on ECMO, we're able to rest the lungs. We're able to allow ECMO to oxygenate and ventilate our patient. And so thereby, of course, like I said, decreasing peak airway pressures and driving pressures. So then we're trying to figure out what is our optimal PEEP going to be. Optimal PEEP can be defined as having appropriate gas exchange. We want to keep our lungs open, so preventing atelectasis, avoiding alveolar hyperdistension, and then not compromising our hemodynamics. So patients with ARDS receiving mechanical ventilation are at risk of developing that ventilator-associated lung injury, kind of going more in depth of reminding ourselves, what does ventilator-associated lung injury, what are those aspects looking like? So damage from high volumes, causing volume trauma, injury from high pressures or barotrauma, atelect trauma from repeated opening and closing of the alveoli due to low lung volume. So again, with ECMO, we can avoid that by we're not asking our lungs to ventilate as frequently, so we're able to come down on our respiratory rate, so not having that repeated opening and closing. And then biotrauma, so looking at lung injury due to a body's response to tissue damage that can result in other organ failure. So all things that we want to avoid. So our institution follows the ELSO guidelines for mechanical ventilation. So this is in their most recent updated guidelines from ELSO. So recommending an inspiratory plateau pressure less than 25 centimeters of water pressure, a PEEP greater than 10, a respiratory rate somewhere between 4 and 15, and then or spontaneous breathing, and hopefully weaning that FiO2 down to 40%. And again, by weaning those vent settings, then our lungs are then able to rest, and we're using the oxygenator of our ECMO to help oxygenate and ventilate our patient. So we can see here, there was a study done by Ko et al. Demonstrated in a prospective study of patients intubated for ARDS related to COVID-19 that there was a change in compliance in 59% of patients when changing from supine to prone position. In almost half of those patients, PEEP had to be changed by 4 centimeters of water pressure to achieve best compliance. So in our prospective work that we did, we were able to see that adjusting the PEEP based on individual positions, whether we were turning the patient left to right or keeping them supine, we could see improvements in oxygenation and ventilation, and we were able to prevent de-recruitment using the EIT by using the EIT tool that offers PEEP titration to help balance over distension and collapse in conjunction with lung compliance. And so again, so we can hopefully mitigate ventilator-associated lung injury. In terms of methods and patient selection, EIT was used to measure and adjust PEEP based on lung compliance and distribution of ventilation with patients in various positions. Ventilator settings and ECMO parameters were adjusted to minimize lung injury and improve oxygenation. So again, I'm going to go a little bit more in depth with the 2 patients that we used in this study. So again, patient A had influenza, MSA pneumonia, and aspergillosis resulting in ARDS, and patient B also had influenza, resulted in ARDS, but also had acute renal failure. So just because I like it, if I know, like, hey, we did this work with this patient, did they survive? Did they do well? Spoiler alert, thankfully, these patients both did very, very well. Patient A was on mechanical ventilation for 10 days and then was placed on ECMO for 45 days, so a decently long run, but thankfully was able to then come off ECMO, was in the hospital for a total of 84 days, and then discharged for outpatient rehab, and their trach was actually removed before discharge, and from what I know from follow-up, that patient continued to do very, very well. Patient B was on mechanical ventilation for 6 days prior to being placed on ECMO, was on ECMO for a pretty short run of only 12 days, 38 days total in hospital until they were able to discharge to home as well for outpatient rehab, and also thankfully were able to have their trach removed before discharge. One of the sort of barriers for this patient was that they had a notable larger body habitus, but was thankfully able to be cannulated. I know oftentimes a higher BMI can be a barrier to us placing patients on ECMO, but thankfully our team did not have any issues with placing this patient on ECMO, and the patient was able to successfully wean off ECMO, and I know they continue to thrive as well. So over the next several slides, I'm going to go over with you all what exactly does the procedure for PEEP titration look like using EIT. Again, as a respiratory therapist, when somebody's talking to me about a new technology, I want to know, what am I looking at as a respiratory therapist, as a bedside person? What am I having to set up? So I'm going to kind of go over that with you all over the next few slides. Again, I'm not going to go screen by screen, but I am going to go over kind of the different components you as the RT are going to have to set up for these patients. So for our PEEP titration, we use the Enlight 2100, which is a device made by Temple Medical. This device it's actually 2 separate belts that come together, and then there's 32 electrodes total that are applied to the patient's chest. So with our two patients, our PEEP was set at 15 and 22 with a decay threshold of 2 centimeters of water pressure. That's just a fancy way of saying that whenever we made our PEEP titrations, the PEEP was decreased by 2 centimeters of water pressure each time. And then for each of those steps, there was a countdown time of 30 seconds. So we would start at that higher PEEP to recruit the lung, then the machine takes its measurement for 30 seconds and then comes down by 2 centimeters of water pressure of PEEP for each of those measurements. You can absolutely start at a higher PEEP if any of you are feeling like that's not a high enough PEEP or something. I mean, it's kind of high PEEP to me, but it really depends on what your patient will tolerate. How do we know what they'll tolerate? The same as we know as RTs have, as we do recruitment maneuvers with patients. You can watch your tidal volumes, if saturations get worse, if you're starting to get tachycardic, if your blood pressure is dropping, those sorts of things. So for patient A, we started at 15, and patient B, we started at 22, because if we went higher than that, we started to see compromises in our patients would get tachycardic or hypotensive. And so we decided to dial in those PEEPs at those levels. But you can see that there is some variability between patients. So in terms of the accessories, again, you can see here's this picture in the upper right-hand corner. That was on one of my previous slides. If we've got the console next to the patient, usually I have it on the same side as the ventilator, because if I'm making changes on the ventilator, I want to see how they reflect with the EIT machine. But then we've got our components here. So there's two different bands. There's a left and a right that are separate. So it really makes it easier to apply this to a patient. And then you plug those into the machine. There's what's called an adhere. This is a single-use strip that goes around the bands. You can see here on the right side where you can see where there's the band that actually has the adhere on there. There's these clear windows that allow that for the belt, for the sensors to read through the patient's skin. And then there's also a proximal flow sensor. So this is a flow sensor that's hooked up to the Enlight 2100 console, and then it goes in line with your circuit. And then you can see that the belt is applied between the fourth and intercostal space. Generally we're going just kind of under the armpits here, and you're going to need a few people to help you turn the patient to apply one belt, get that one belt applied, and then turn the patient the opposite direction to get that next belt applied there. This is just another image that I wanted to include because, again, you want to know, how is this looking sitting in my room? There's also a reference cable that is part of the system that helps for the electrodes to pick up from the console. So you can see here's where the belt, you've got your flow sensor, the reference cable. So there's only really three things that you have trailing from the machine over to your patient, so not a lot. So finally, this slide, I will kind of go into more detail of what our actual patient results were. But you can see here that why I wanted to include this slide is that it helps us to understand or get sort of a brief understanding of, once we get our PEEP titration, our different parameters that we're looking at. So we're going to get images that are going to look very similar to you. If you've never seen EIT images, they look a lot like a CT scan slice, right? But we're kind of looking at a few different things. We're looking at hyperdistension, collapse, and compliance. And we get to look at hyperdistension and collapse from both quantitatively and then also a visual aid. So for hyperdistension, you can see here that's going to be displayed in white on our scan. The white you can see is it gets brighter as we get more hyperdistension. So that is associated with a higher risk of volume trauma, so lower compliance and lower gas exchange. Here we've got collapse that you're going to see in blue. So that's going to be at a higher risk of ADELEC trauma. Again, lower compliance, lower gas exchange. And then finally, we're going to get a quantitative data set that's going to show us what our PEEP is as we've gone along, It's going to give us a quantitative data readout of what our actual hyperdistension and collapse is, and then our compliance. So of course we want best compliance, least amount of collapse, least amount of hyperdistension. Again, this is just to kind of orient you to some of the images and quantitative data sets you're going to get as we do our PEEP titration and kind of help you to understand what these separate images are going to look like. So this is an image that I don't need you guys to necessarily look at what each of the numbers are, but this is a PEEP titration report that after we complete our PEEP titration, as I said, you set your higher PEEP to recruit the lungs, and then you perform each of your steps for 30 seconds, and you have your PEEP decay of 2 centimeters of water pressure for each step. But you're going to get 3 different things. Okay, you're going to get this graph over here that you've got your collapse in red, you've got your hyperdistension in blue, and you've got your compliance in green. And you can see here on your horizontal axis, this is reading your PEEP. And then your y-axis on the left, you've got collapse and hyperdistension. And then on your right, you've got compliance. And then if you come over here, you can see with each step, you have a visual representation of that hyperdistension and collapse. And again, you're seeing it in white and then in blue. And then you can see that the numbers from your table are also echoed in each step here. So a lot of this data is sort of repeated, but this is really to help you understand and decide from a clinical perspective, where do I want to set my PEEP at with this patient based on the best compliance with the least amount of hyperdistension and the least amount of collapse. You can also see that you've got a table over here with your PEEP setting. Every time that you're turning down your PEEP, your compliance, your hyperdistension and collapse, and then these different images. So for our next slides that I'll show when we get to our graphs and reports, I don't have a full page set out like this. What I've done is I've broken down from each measurement that we did. I'll show you the graph, the table, and then the kind of in between the 2 steps that we ended up making our decision based on of how we determined what PEEP setting we wanted these patients on. But this is what you're going to get whenever you perform a PEEP titration on EIT. So for a procedure of PEEP titration, patient A and patient B, we ended up doing a little bit of different things. And again, I do like that with both of these patients, we did a little bit of different something because, again, these ECMO patients, they're placed on ECMO because they break conventional methods of medical management. So why would it be a conventional method of, not every single ECMO patient is going to be the same every time. And so I love that these are a little bit different than what we expected initially. Patient A, both patient A and patient B, let me back up for a second. Patient A and patient B, both of them, we took EIT readings on them prior to them being placed on ECMO. However, both of the patients, they continued to decline. They needed to be placed on ECMO. And we had initially thought with patient A that we would be able to do EIT settings right after the individual was placed on ECMO. However, they were pretty unstable. They had a lot of hemodynamic challenges. So we were kind of trying to be a little bit more delicate with them. And so we didn't actually do it on the first few days. So if you go here on your left side column, you can kind of see along with me that the belts were actually applied and we were starting to wean off of our paralytic. And so before we fully weaned off our paralytic, we were able to take EIT measurements on days 8, 9, and 10 of ECMO. The belts again were used at this time because the patient was unstable in the first several days. On days 8 to 10, we were able to slowly wean off that paralytic, but the patient still was not creating active respirations, and so we were able to use that PEEP titration. As for patient B, the belts were used again prior to being placed on ECMO, and then on ECMO days 0 to 2, so for 3 days, and we were able to titrate the PEEP based off of those readings, and then we were also able to use EIT to track changes post-bronchoscopy and further titrate our optimal PEEP with that. So you can see these are our chest x-rays prior to ECMO. You can see these patients are very, very whited out. You can see on patient A, our left side of the lung, we had complete whiteout. There is actually not terrible aeration on the right side, but the patient was still very hypoxic, becoming hypercarbic. You can see here, just because I love looking at a chest x-ray as an RT, just to orient you, you can see the patient had some hardware here in that right shoulder. And then you can see here in patient B, complete whiteout. Very, very little ventilation. You can see our trachea here and our carina. Now you might be wondering, what are these little squiggly lines across our chest here? So these are actually our EIT bands. So if you're curious as to one, if you could do a chest x-ray with EIT in place, yes, you can. And then two, if you are going to see those bands when you do a chest x-ray, the answer is yes. So I'm going to tell you guys on this slide kind of the things that we were able to do with EIT with each of these patients, and then I'll dive into how we got to those conclusions based upon the readings that EIT gave us. So patient A, again, that flu, MSSA, aspergillosis patient, very, very sick patient. We were able to use EIT measurements to indicate our best PEEP in different positions. Again, if we go back to that last slide showing that chest x-ray prior to ECMO, you can see that left side is whited out. So whenever we turn this patient, when we try to go left side up, the patient would just desaturate wildly into the low 80s, upper 70s. So we're like, okay, left side's not an option. So really, we were able to use the EIT to help dial in our PEEP. We might have did like a micro turn on the left, but we predominantly were laying supine, or we would go right side up about 30 degrees. I would tell my nurses, hey, can we get this right side up as much as we can? And when we did that, and when we performed our EIT, we were able to see that our TIT set in the supine position was best at 8. But when that right side went up, our best PEEP was actually at 12. So by making these adjustments and by moving our patients in these positions, we were actually able to see minimized hyperdistension and collapse, improved oxygenation, with a reduction in our FDO2 from the ECMO circuit. We went down from 75%, finally down to 50, and while we maintained a saturation 94%. That also being said, again, we were on we measured these on days 8, 9, and 10. Prior to that, we really couldn't get our FDO2 on the ECMO circuit down from that 75%. So we're very glad with that progress that we made. Patient B, again, had flu and ARDS and acute renal failure. So the patient, again, was placed on EIT prior to ECMO to optimize PEEP. However, the patient continued to worsen. So post-ECMO cannulation, we were able to use EIT to adjust the PEEP and track ventilation distribution changes. I will say as we go along that we actually had kind of zeroed in on where that patient's PEEP needed to be around 18. And so our big changes with this patient really came when we were able to use EIT and we performed a bronch. So after that bronch, we were able to reduce the PEEP from 18 to 16 when we performed a PEEP titration. We noticed that lung compliance increased from 12 to 20. Our tidal volume, I think, was probably one of my biggest happy gains of a tidal volume improved 40 milliliters to 237 milliliters. We had a resolving respiratory acidosis from 53.5 to 48. And then we improved our oxygenation from 72.9 to 105, and we were actually able to wean off our nitric oxide. Again, you're going to see in our next slides how we were able to actually track improvements with the patient post-bronch, which was about 10 minutes after the bronch, and then we did it at the 2 hours and 3 hours mark. So the improvement in the patient distribution mapping correlated with improved ventilation and oxygenation. And again, we'd been struggling to get this patient off nitric for the first couple days. So now is coming into a slide that I know initially looks kind of busy, but again, that's kind of why a few slides back, I took you through what did that PEEP titration look like for when it comes out on that after you perform your report. So this is where I have kind of reduced each of those days down to the graph, our quantitative data set, and then our images. So you can see here, again, orienting you to your graph, you have your collapse in red, you have your hyperdistension in blue, and you have your compliance in green. And so you can see that when these lines intersect, they give you a line of best fit. So our line of best fit here is saying about 7.2. And then when you come over here, we have our quantitative data set. And then I have just whittled down the images instead of taking up an entire slide by 1 day of PEEP titration. You can see that I have our images here. And so in the blue is what I've highlighted as what PEEP we settled on. And let's talk about really the pot of gold at the end of the rainbow here with what we're looking at with our PEEP titration, right? Like we get the data set, we get the graph, we get the images. How am I choosing this? So again, I want best compliance, least amount of hyperdistension, and least amount of collapse. And of course, by the way, you're still on the outside of this looking at what is my patient doing? What's their saturations look like? So you've also been cognizant of this while you're doing your PEEP titration. So if you look over here at our visual representations, which is one of my favorite parts of EIT, because you get that nice slice that looks sort of like a CAT scan image. You can see as we start to go down too much on our PEEP, we start to see some more collapse. And then you can see over here, more PEEP is not always best. You can see here when we were at a PEEP of 14, look how wildly hyperdistended we were, 52%. And our collapse was 0, but it's because we're super hyperdistended. So thankfully, as we start to come down on our PEEP, our compliance is getting better. And then finally, we settle out at only 6% hyperdistension and just a little bit of collapse. So we decided to leave our patient here at a PEEP of 8. And you can see even visually just how little representation of hyperdistension that is and very little collapse. So that's how we decided to stay there at a PEEP of 8. So this is in the supine position. So if you remember back from our slides before when I was discussing what happened with our patient, again, this patient A with that left lung that was fully whited out in the supine position, we'd be at a lower PEEP, and at the right side up, we were able to tolerate a higher PEEP. So if you go down here to day 9, we were right side up, left side down. You can see here we've got a PEEP of 12, and then we've got a little bit hyperdistension, and then our collapse here is at 17%. Again, I could see how people could kind of be caught between these two numbers. If you really want to, you could set your vent at 11. That might drive you a little bit crazy. I'm not saying that it's totally out of the realm of what you can do to set it at an odd number, but usually you're kind of like trying to choose between the even numbers here. And so we actually decided to go with 12. And the reason for that was our physician was kind of worried about if our patient ended up moving some, or were we going to create some more collapse. And so we kept us at that slightly higher PEEP of 12. But you can see even by going down by 2 centimeters water of PEEP, you have quite a jump and collapse. So eventually you can kind of go back and forth, and you're splitting hairs. You have to make a decision, and we decided to go with the PEEP of 12. Over here on our next measurement on day 9, you can see when we went supine in that same day, our PEEP, our line of best fit is saying about 6. But when we went over to our table here, we can see that at about a PEEP of 8. Now, some of these are, it's sort of a little bit, we're going by the odd numbers here. We decided to go kind of in between these two of 7 and 9 and went with about 8. Again, you can look at your images here and you can see what your collapse and hyperdistension looks like and look at your values. So again, we decided to stay with a PEEP of 8. And then on day 10, again, we looked at what our measurements were with the right side up, left side down. Again, looking at our images here, and looking at what our hyperdistension and collapse would be, you can see you can actually get quite a bit of remarkable collapse as we're starting to lose PEEP here. And so before we collapse any further, we just decided to stay at a PEEP of 12 here. So it went kind of between those two numbers there. So jumping over to our patient B. So this was the patient, again, that had influenza, who had ARDS and acute renal failure, and had a little bit of a larger body habitus. So we knew that we were going to need sort of a higher PEEP. You can see that we started at a higher PEEP of about 22, and then we took multiple steps down. Now you might be wondering, going back to these other graphics, why sometimes are there 5 steps or 6 steps? Why are there sometimes 5 steps? It really was kind of what will a patient tolerate? And so, especially with this patient, because I wanted to see, usually we think, again, do larger patients need higher PEEP? Could they tolerate lower PEEP? So I ended up going more steps on this patient. So we started at a PEEP of 22, and you can see as we start to titrate our PEEP down, our compliance stayed relatively the same, but we're finally starting to see a loss of hyperdistension, but then we're starting to have a little bit more collapse. So we stayed at that PEEP of 18. And again, you can see really from a visual representation, if I would have went down to 16, how much more visually I'm having more significant collapse. And then really how seemingly insignificant the hyperdistension collapse seems at step 3 with a PEEP of 18. So we selected for that. This was approximately 2.5 hours after being placed on ECMO. And so surprisingly, really not a lot of change. We again saw that there wasn't a need to change our PEEP from where it was, but I do want to highlight this. Look at how much, if we would have went down to a PEEP of about 16, how much collapse there would have been. And you can see that in the numbers from our quantitative data set, and you can see that in the imaging here, how much our lungs collapse as we reduce PEEP on this patient. This is about 16 hours after being placed on ECMO. Again, no change to PEEP with EIT, or the vent remained on 18 centimeters of water pressure. Again, compliance overall was not great with this patient in the initial day of being placed on ECMO, but I don't expect it to get better from one day of being on ECMO and lung rest. Again, I think most people know with ECMO, it's can sometimes be more of a marathon than a sprint. And then you can see that we've lost our hyperdistension. We're just starting to get a little bit of collapse. And so we said, let's stay at 18 here. And then finally, 24 hours after being placed on ECMO, there was no change to PEEP with EIT. We remained at 18 centimeters of water pressure. And then you can see here, again, the visual representation. We're starting to lose our hyperdistension. We're starting to have a little bit of collapse, and then significantly more if we would have went down to 16 of PEEP. And so you can see here on the table as well, both of those highlighted in blue, which selections that we made there. So approximately 46 hours of being placed on ECMO, and then this was also 3 hours after our bronch. So this is actually where we are seeing a change. Those last 3 slides, you can say we just stayed at 18, we stayed at 18, but then after we performed our bronch, we performed another PEEP titration maneuver. So per the EIT calculation and graphics, we weaned actually to 16 centimeters of water pressure on our PEEP. And then we were also able to wean from inhaled nitric oxide after the bronch and the PEEP reduction 2 hours later. So you can see if we were at 18, we would have had quite a bit more of hyperdistension, and we're just starting to have some collapse there. So, and we weaned the PEEP, and the patient tolerated it very well. And again, like I said, we were finally able to get off that inhaled nitric oxide. So that felt like a big jump in the right direction. So this is now going to be a totally different graphic than the ones that I've been sharing with you all. This is another feature from EIT that we're thankfully able to use. So this is, again, still patient P, so pre and post bronch. So this first map up here is before the bronch and then 10 minutes after. The second map is 2 hours after, and this third one is 3 hours after. So I'm going to kind of guide you all through each of these here, you can see here that we get anterior and posterior measurements and left and right. And then 10 minutes after, you can see now that we have some better ventilation to our right side there with this patient. Again, if you remember this patient's chest x-ray, they were very whited out. You can see in the red circles here, we had a tidal volume improvement from 40 to 136. And then finally, going down here to our post-bronch, you can see, again, our distribution from anterior to posterior and right to left have improved from that reference point from when we first took our measurements on the patient. And then you can see that in the red circles, our tidal volume improved 10 minutes, 136, to 2 hours to 214, to 3 hours to 237. And you can see from our change map here, our increased ventilation throughout as our patient's lungs are starting to open up after that bronch. So in patient A and B, in both cases, we were able to individually select ventilator settings based on best compliance with least amount of hyperdistension and collapse. And again, that for me was really the exciting thing, to use EIT with these ECMO patients, because again, it's really a not well-defined thing out in the ECMO community. I think we've been very lucky that we have been able to come up with guidelines, but as we know, each of these individual patients can be very different due to body habitus, due to disease process. You know, we can say ARDS all day, but we know that each of them can have their different barriers and different things that we need to tackle. And so I think as RTs, we know it from the bedside. When you turn a patient, you know, with their left side up and you know, like, oh, well, they have a lot of whiteout on that side. They're not going to ventilate really well. But it's really hard to make that argument of changing the PEEP because you don't have that bedside tool to always quantitatively tell you what those numbers should be. So we were able to individually select those ventilate settings for these patients. We're able to wean our FiO2 and or inhaled nitric oxide significantly while maintaining our saturation goals. And then we're also able to continue to monitor ventilation distribution improvements over a series of days beyond our tidal volume exhaled on the ventilator. So, you know, having more quantitative results to be able to say what improvements we're making, are we having a setback, and then, you know, also going back to that slide where we're looking at our bronchoscopy, if we were starting to, you know, seeing changes in our distribution map, if these were start to worsen, you know, and if we started to see a decrease in what our percentages were, you're able to also kind of zero in on, hey, where am I having those changes in distribution? Is it my left side? Is my right side? Is it anterior? Is it posterior? So having more of a guide than just the classic chest x-ray of, do they have a mucus plug? And this patient did significantly have a mucus plug. They were able to remove and then see those improvements and track those changes. So for our continued research plan here at University of Missouri Healthcare, we're looking at collecting data to be used for case studies with patients requiring VV ECMO who are eligible for the EIT belt that will be used to optimize ventilator settings and guide bronchoscopy intervention. Our early results are indicating improved ventilation distribution using EIT-guided PEEP, particularly after bronchoscopy. And then, like I said, using EIT to look at real-time monitoring before and after bronchoscopies or any other procedures can hopefully help to continue to detect ventilatory changes and allow for timely interventions before a patient would deteriorate on their own. So in conclusion, EIT can be a safe and effective tool when used in conjunction with ECMO to reduce ventilator settings by achieving the goal of reducing hyperdistension collapse while maintaining ventilation at the best compliance. EIT also can offer the capability of determining different levels of PEEP in patients who may be presenting with differential lung disease, with portions of lungs more and less compliant than other sections of lung, dependent on position or time during an ECMO run. And these are my references. Thank you to my collaborators and my support team, Dr. Tinashe Maduke, Dr. Shyam Shankar, who's our medical director of the ECMO program, and Troy Whitaker, who's the medical ICU respiratory team lead. Thank you all so much. There's my information there, as well as a QR code that can link you to my information. Again, I really, really love talking and working with people who do ECMO to troubleshoot for their programs, but also myself. I very much admit that I'm always looking to grow, and I love it that there are often those problematic patients that I'm able to reach out to my community of ECMO and respiratory therapy people out there to help deliver quality care. So thank you all so much for your time. Thank you for listening.